right. And then just want to share that myself, Dr. Elizabeth Brewer, and then I'm joined by my colleague, Dr. Emily Peterson, and together we chair the Caregiver Wellbeing Committee, and we are going to be your discussion leaders today. I see many familiar faces on here, so I think we've got some frequent flyers to the Inclusive Care series, which is awesome to see. I'm so glad that you guys are finding value in this. So as we get started, just know that this book club is not me and Dr. Peterson talking for an hour. We really want this to be just a good discussion, interactive, filled with really great insights that you found as you read the book, or your own insights on this topic, whether you read the book or didn't. I think that there's a lot to be shared here. So your questions, comments, and insights are definitely needed. You can please participate either verbally or through the chat. We really want to hear from you. Anything else before we get started, Dr. Peterson?
No, I think that sounds good. I'm ready to go.
All right. So just really quickly, I wanted to summarize sort of the overall content of the book. If you did not get a chance to read it, but still are interested in participating, this is what it was about. So the tagline on the book is "One Doctor's Passionate and Profound Memoir of His Experience Grappling with Race, Bias, and the Unique Health Problems of Black Americans." So Dr. Damon Tweedy is the physician that wrote the book, and it's about his experience as well as the experience of the colleagues that he worked with, his patients, and it takes place mostly during his medical education when he's a student at Duke, learning to be a physician, and then during his residency as well. So he has been practicing for many years now, but this is primarily taking place during that time period of his life. So through Black Man in a White Coat, though Black Man in a White Coat focuses primarily on his thoughts and reflections on his medical training, he's far from the book's only source. Drawing from other memoirs, history books, public health studies, and various other resources, Tweedy weaves a complex tapestry of information in support of his observations. So not only is it what he has observed, but he has evidence that he presents as well to support a lot of the observations that he makes. He tells this story in 3 parts, focusing first on disparities, the barriers, and then perseverance. So he does end on a fairly positive note, which is nice to see. He touches on lots of different topics, not just race or what it's like to have an experience as a Black person in America, but he talks about affirmative action, teenage pregnancy, charity care, hate, discrimination, HIV/AIDS, and just generally doing the right thing. And really touches on actually quite a few different diverse groups, the LGBTQ community, economics, diversity, really a wider range than just racial diversity. So overall, I really enjoyed this book. I know Dr. Peterson did as well, and I'm sure she can share her thoughts, but I would love to hear just from the group generally, if you had a chance to read it or skim it, what were your initial thoughts? Did you find value in it? Did you like it? Tell me more.
This is Christy from 3 East. Can you hear me?
Hi, Christy.
Hi. So this was another great book, I thought. It was one I didn't want to put down. And I just thought, just for the reasons that you mentioned, I could connect with so many different things. And I actually went to nursing school in Ohio, but I'm from Philly. And so it really rang true to a lot of things that I saw early in my career, both with doctors and patients. So yeah, it was a really good read.
Thanks, Christy.
Yeah, I felt the same thing. Like I couldn't put it down. And Elizabeth said that just the other day too.
I read mine on vacation. That's how good it was. Any other initial thoughts?
This is Shannon, one of the nursing education specialists. Can you hear me?
Yeah,
Yes.
Hi, Shannon.
Awesome. I just thought it was really, really interesting. A couple things. One, talking about like the standard of care that was provided when maybe a care provider had different information about a patient, I thought was very interesting. Like if the healthcare provider knew that he was a physician or um, expected IV drug use or whatever that factor was, how that really affected the care and like diagnostic testing and that whole trajectory. And do you not want spoiler alerts, or is it okay?
It's spoiler alerts, I think, are fully approved here.
Okay. I personally found it very, very interesting when he spoke about disparities with HIV/AIDS
Mhm.
and how that landscape really changed over the years, and how the kind of secrecy and shame with sexual identity really impacted um, even talking about it, using protective measures, seeking healthcare, partners who had really severe outcomes when they, because of that kind of shame culture, that it wasn't just the medical care that affected outcomes.
Right. Yeah, I mean, it's such a devastating story, the couple of stories that he shared about HIV and how it was contracted and spread to other people within the community. Just to describe that firsthand, it was really powerful. And, thankfully, things have changed a lot in the landscape of HIV and AIDS, but I think the lessons from that time period kind of are still coming out. I mean, this is, like, I think HIV was first diagnosed in the early 1980s, and he was seeing these patients 20 years later and still struggling with secrecy and shame. So it's interesting.
Thanks, Shannon. Appreciate those comments.
Yeah.
All right. Well, please keep it coming. I'm so excited. I do have some discussion prompts for us to keep us going. So I'm going to go ahead and kick it off with our first question. Shannon sort of started in this direction. So was there a specific passage or incident that left an impression on you, good or bad? There were lots of different vignettes throughout the book. So is there one that comes to mind that you want to share? I'm looking at it on my phone so I can pull up my highlights here.
Yeah, I think I mean, for me there were so many stories that he described, but the couple that I remembered, even after having put down the book 2 months ago, the couple that really stood out in my mind were when the professor asked him if he was there to fix the lights. That was one, in that I can just imagine how he felt in that moment to be, you know, to have that professor not see him as someone who is worthy of being a medical student potentially, that he had to have been there to fix the lights. The other couple that I thought were really kind of triggered a lot of additional thought for me were the one where the patient was a Black patient with high blood pressure in the hospital, and they recommended that he start a medication for it. And the patient wanted to um, try diet and exercise and then follow up, which is a reasonable thing to request. And there was a label that was placed on the patient in a mental health diagnosis that was placed in the patient's chart about his quote, refusal to comply with medical management. I thought, just thinking back to all the things that you kind of might cavalierly put in a patient's chart and how that moves with them through time and different locations and affects how other people who might be seeing that patient for the first time affects how they're going to see them. I thought that was really kind of eye-opening. So those couple stuck out to me. Anyone else?
Don't be shy.
This is Christy again. There were so many points in the book, but one that I thought about was when they were taking care of the patient kind of towards the end of the life, and how there was a lot of tension about what type of doctor was going to take care from both the patient and the family and multiple family members. But then as they had confidence and built that relationship and didn't shy away, how there was trust and, bonding, and then even a good outcome in the very end. These patients take time, and we're on all different shifts sometimes, but anyway, I appreciated that. And then I think just throughout the book, and I was so thankful that he read his own story, but all the different things about, like, that I connected with was as far as just like personal bias, even if we're trying to fight against it. What our peers think, what our coworkers think, what patients think, what families think, and all that processing that goes through as we're, trying to be just. And he just brought it through on so many different levels. So that's it.
Thank you. Yeah, he really did a full 360 kind of look at bias and discrimination from so many different points of view. It was really rather remarkable, and he was very vulnerable about his own thought process too. Oh, go ahead.
No, I was just going to make a comment. Go ahead.
Oh, that's okay. This is about you guys, not about me.
I guess with this book, the title itself was just something that I was interested in, because growing up down south, I was really, really able to resonate with what he had written, especially the parts about laughing at your pain, the part about Chris Rock and having to reflect to a joke, and having to, when he wrote that, I automatically laughed, because there were times where I had to do that. I know when I was in school, I went to a HBCU, and it was a little differently. It was a little different, I guess, as we started to go through our nursing curriculum and starting to step into our clinicals and the way we were perceived as students. And it just took me back to that point, because it was a different way that we were taught, that we even had to enter into the healthcare field, and how we would be perceived. And there were points in the book where he wrote about that, and I even called to speak to some of my old nursing instructors and spoke on it. And she was like, "Oh, I'm gonna have to read this book myself just to see if it's a way that I can sneak it into the curriculum." I said, "Yes." I said, "I like that, because you often hear of people speaking of it, but not necessarily writing about it and it relating." So I like that.
That's great. Thank you for sharing.
Yeah.
That one of those kind of the unwritten rules, right, or the unwritten culture that isn't transparent to everybody, and we could do a better job of that for sure.
I don't even know sometimes if it's unwritten or just the fact that you're just trying to move past it.
Yeah. Thank you.
Yeah, thank you.
So one of the sections that I'd highlighted was towards the very beginning of the book, when he was a first or second year student doing a rotation in the OB, and the young Black patient who was on crack that came in to have the baby, and just how everybody was so immediately, they stereotyped this woman, and, you know, maybe they weren't wrong about their assumptions in the end, but how he said that if he had to be honest with himself, he felt disdain towards her too, even more viscerally, because she was putting the worst face on Black America, and like he felt let down for his own people. And I thought that that was so interesting. I had an experience once, not as a white person, but as a woman, where I was trying to help a customer in a store, and the woman didn't want to speak to me about electronics because I was a woman. And just that, like, within your own, you know, your own cultural group, that same stereotyping or the same issues with behaviors and things like that. That was, I thought, was very interesting that he felt that way, and how he worded that. All right, let's go to the next question. So I think this is about the patient that Christy brought up. His name is Chester in the book. It says, Chester hated Black doctors and female doctors, yet Dr. Tweedy turned this situation around. So if you recall, or to summarize, Chester was a patient who was admitted with some lung issues, and they ended up finding out that he had some complications, but also a very aggressive form of cancer, and he was probably not going to leave the hospital. So that initial admission through the end of his life, Chester hated Black doctors and hated female doctors, and that was who his team was that first came to him in the hospital. So presented with that, what do you think the factors were that turned that situation around? Any thoughts on that? Or observations from your own experience in similar situations?
I saw a couple things. One, there were a couple examples, not just this one, where Dr. Tweedy basically shared that he had to demonstrate his competence. His competence was not assumed. He had to show that he was competent, that he knew how to treat that patient and was a knowledgeable part of their care team to kind of earn that trust and respect. And then another piece was finding a way to identify with the patient as a person, finding something that's of interest to them, that matters to them, and finding that thing to relate on instead of letting the barriers kind of halt it right there.
Yeah, that's nice, Shannon. Thank you. I think they connected about baseball in this case. Chester had a baseball game on in his room, and they started talking about it. That non-medical connection is so important to humanizing not just your patient, but humanizing your doctor as well, or your care team. Because gosh darn it, we are all just people doing a good job.
Yeah, I agree. I think it was his ability to humanize the patient, even though he was, being pretty hateful. The patient was being hateful and racist and awful. He was able to go in and find something in common. And I think, Elizabeth, you remember Ben Earwaker from the Idaho Human Rights Coalition. I can't remember exactly the name of it, but he talked about that. Even everybody has an aspect, they have humanity. Everybody has humanity, and you can find that in everybody. And he talked actually about going to the Pride in the Park this summer and talking to some of the people that were protesting with guns, and kind of trying to find the humanity with them and make a connection, which I thought was, it's not exactly the same thing, but someone's behaving badly, you can dismiss that person pretty easily, say this is just a bad person, but we all have humanity, and you can find it if you are willing to make the effort.
Great. So Chester and Dr. Tweedy's relationship changed throughout the course of his hospital stay. And at one point in the middle of the stay, Chester, having been very dismissive or maybe not even talking with Dr. Tweedy up to that point, Dr. Tweedy asked, "How are you feeling today?" And Chester finally responded and acknowledged him and said, "Okay, Doc, I think I'm getting better." What do you think that impact was on Dr. Tweedy with that response? Even just using his title, doctor, or shorthand, like they're familiar with each other. That validation, I think, that we spoke about right at the beginning, that you have to prove yourself over and over and over again. And that finally showed that Chester maybe believed that.
Maybe he thought about it as maybe this was a great breakthrough to move to another step in his care. And if he was able to acknowledge him as a doctor, then maybe he would allow him to further treat him. Just my thought.
Yeah. Oh, that's great. And there's a lot of research out there that when patients are more engaged in their experience, that they're more likely to adhere to their plan of care, right, or their treatment plan. So that, that trust is so important in patient outcomes for sure. So lots of opportunities throughout this book for learning. And Dr. Tweedy was a really good example, I think, of how to ask empathetic questions and make those connections. So what did you pick up from him? Are there any strategies that you learned as you were reading the book that you might incorporate into your own practice? Or anybody with their own stories of how they may have been in a similar situation?
What comes to mind to me is when he was asked to see the young lady in his psychiatric practice, I guess. And at first, both he and the patient's reaction was like, "Oh, I really don't know about working with this person. I don't know if it's a good idea." And instead of just being like, "Oh, she asked for somebody else," or "I feel uncomfortable, I'm going to kind of turf her," he went and really processed and thought about it and sought colleagues' opinion, and decided to do something that made him uncomfortable and to do his very, very best for that patient. So I think that that's something when we're uncomfortable, we can stop, say, okay, why am I uncomfortable? What am I afraid of? What really is the right course of action in this? If I'm not the best person for this patient for a legitimate reason, I should do what's best for the patient. But if I'm just uncomfortable or we're afraid of kind of dealing with this elephant in the room, then how can we go about that? So I thought there was a lot of self-awareness and processing that we could learn from.
Thanks, Shannon. Love it. Yes. He was very, I think, transparent with his patients in many ways. What else?
Yeah, I think the thing that one big takeaway from it for me is the ability to be able to look at yourself as, not necessarily the hero in your story, right? So I think and if you do end up watching that Duke book club, he talks about that in there, that, one of the questions was, did any of the people, or did you talk to any of the people you described in the story before you published this book? And he did talk to some of them, but he said, I come off just as badly as any of the people that I describe in the book. I'm not describing myself as being, the perfect doctor or the perfect person. He's looking at it from a personal perspective as well. So I think the the ability that he has to be able to look at himself that way and actually write it down and publish it for millions of people to read, I think is pretty amazing, humbling.
All right, I'm going to turn it over to you, Dr. Peterson. I think this is your question here.
Okay. So he wrote in the book, at least once a day during my rotations, my race would come up, or an interaction with patients usually implied instead of usually implied instead of explicit. The insults didn't stop once he became a doctor. And first question, what were your thoughts as you read about these encounters and interactions? So, stereotypes in general, what were your thoughts as you read about the different stereotyping? And one of the things that I just wanted to say that he spoke about in that book club is the difference in response as it relates to the power differential with the person who's talking, who they're talking to, who they're interacting with. So it's a very different interaction in the first kind of scenario where the professor asks him if he's there to fix the lights. It's going to be a lot more difficult for him as a student of this professor to confront or say something to this professor. And it's going to be a different scenario if it's a patient and you're the doctor and the patient's saying something that is discriminatory, or if it's a colleague. And it's a very different interaction depending on the power differential of the people who are having the interaction. And probably significantly changes how you're going to handle that situation. And if there were other people present too, if you're just there by yourself with the other person and they say something, it's different if there's a witness, if there's somebody else, if they noticed it, if they said anything, if they felt uncomfortable or appeared to be uncomfortable with it. So I thought those were the points that he kind of made about it that I thought were fairly interesting and not something that I'd really thought of kind of consciously. So other thoughts from people?
This is Christy again. I think it was a big self-reflection book. That's the takeaway that I had, but also how he sometimes chose to say something and speak up because he thought he would make a difference, and sometimes he didn't. And that was even when there were peer-to-peer situations that I saw throughout the book. And I think he struggled with that a little bit. And then there were times that he spoke up. I think that he often backed up other people. And then I think that there's so much hurt just hearing about different situations where sometimes there's mental health issues or abuse issues, that he had a big heart, or even just with standards of care, back to when Shannon was talking, just there is a difference. Sometimes we can make a difference and sometimes we can't, and sometimes it's just that little part.
Great insight, Christy. Thank you.
Yeah.
I do see that power differential now that you're talking about it, Dr. Peterson. That makes a lot of sense. Like, he did not speak up when it was a professor. He instead internalized and challenged himself to be the best in his class and show him why he was deserving to be there. And then the patient you were talking about that received that mental health diagnosis in their chart, as he was reviewing and signing off on these different charts, he'd see those things, and then as a student, maybe didn't feel like he could speak up or that it was his place in the hierarchy, even if he didn't agree. And that's a really tough barrier to break through.
Exactly. Yeah, I think, and one of the things that he talks about in the book club too is how different things are now than they were when he was going through training. And I remember this about my training. There was no rate my professor when we were going through training. When my cohort was going through, it was, you just got what you got, and you might be able to give them like a 1 through 5 on a paper form or something like that. But there wasn't that kind of, debriefing on what did you really think about your professor. And I don't think we all really felt like it was something that we were able to do or capable of doing. And now, like, if you've taught a class recently, the students have a lot to say. I think students are a lot more empowered to have a say in the quality of their education than they used to be in the past. And he said that, I agree, it's a very positive change. So I think some of this may be different now than it was 20 years ago when he was going through training, where he didn't have a route or an avenue to say anything. There was nobody to talk to. And he just, was left with the worry, if I say something, I'm going to get kicked out of school or there's going to be repercussions. And I think we're not perfect by any means now, but I think things have moved in a different direction where people of authority are actually being held accountable for discriminatory behavior in at least some of the time.
I also saw him kind of wrestle with himself over, like, am I being too sensitive, and am I seeing this through an inaccurate lens? And I, like, if it's really something that should be brought forward, I want to bring it forward. Can I? Is it a safe place to do that? But also, like, it probably wasn't meant that way. And he really wrestled with himself about if he was being sensitive and how he was perceiving things and the right way to handle it. So I thought that inner dialogue was really interesting.
Right. That idea of the microaggressions and, intent versus effect. And people get defensive when you call them out, and it's not going to be an easy conversation no matter who it is. So, yeah. All right. Next question. How was Dr. Tweedy stereotyped, and how are the patients that he cared for stereotyped? And I think we have talked about a number of these. One thing we haven't talked a little bit about yet that I found very interesting was the when he first went to the doctor for his high blood pressure, and was uh, immediately prescribed medications rather than lifestyle modification. That happened later on in the book as well. And that, high blood pressure is more prevalent in Black people than it is in other races. And so there's this cognitive leap. This is a common diagnosis. We just need to treat it. And so I I thought that was really interesting, and that went on to how we chart on patients, which is you see a patient and the first thing that you write in their chart is this is a 34-year-old white woman, or this is a 46-year-old Asian man, and putting race ahead of anything else in their medical history, right? The only thing that goes ahead of race is age. And is that really the most important thing that we need to know? The first thing we need to know about that patient? Is that really the first thing we need to know? And should it make that much of a difference in how we treat that patient? And I think the answer is probably no. No, it doesn't make that much of a difference. It's something that has been, historically we've passed that down as the standard. And it probably does need to be changed. But I thought that was something that kind of leapt out at me when I was thinking about how he and the patients were stereotyped. Anyone else have thoughts on that, on the charting? I thought that was a really interesting point that he made about, and it was something that I have done and haven't even ever thought about, just because it's the way that things have always been done. And I've changed it now, how I chart. But I thought that was fascinating.
I think the stereotyping shows kind of an interesting application of bias, right? So you've got this one view or this one insight into somebody, like their race or their gender, and you immediately make this series of assumptions about potentially their education, their drug use, their financial situation, their family upbringing, their marital status, with knowing absolutely nothing about them other than what's immediately visible. And that that's scary, because those things that we fill in the blanks with, well, natural to do because our minds like complete data sets, we're telling ourselves this story that becomes this truth in our heads, and it's not, it may not even be close to the truth, and likely not at all. So, Dr. Tweedy being stereotyped as somebody in an entry-level job or somebody who's uneducated, and the same thing's happening to his patients as well. And even he doing it himself, assuming that the patient with high blood pressure wouldn't be able to make lifestyle changes based on his experience and his own background. We have to be able to, I guess, recognize when we're going down that path so we can halt it before our stories become the reality.
Yeah. And I think, there are diagnoses that go along with race. It's true. There are things that are most common in certain races, but it's probably not the first thing you need to know about the patient when you're looking at their chart. And it's probably not the biggest factor in what your diagnosis is going to be. And I mean, the other part of that too is, you put Asian in the chart, or you put Black, or you put white, that those categories encompass such a huge variety of ethnic backgrounds that, I mean, Asian, it's like they could be Indian, they could be Chinese, Korean, Japanese, all of which come with dramatically different cultures and genetic predispositions. And so I I just I thought that was such a, it's like a glaring problem with the way that we are looking um, at patients within their medical charts. So, anybody else have thoughts on that? Have you seen that in charts before, and had you thought about it before?
This is Jeanette Berg. I have thought about it, and I think there's kind of is that interesting tension between what race can kind of add in terms of information and what it presumes. And when it's stated in the first line, it's usually also what the physician is assigning. It's not necessarily what the patient may identify with, or you just don't
Right.
know. I actually haven't added race kind of in the opening line. And I guess I'm more comfortable with that to the extent that if I pick up a note, I will remove it from the note I'm picking up from a colleague, which I guess shows my comfort level of it being not in the first line.
That's good. Yeah, that's good to hear. Yeah, it is interesting. Like one of those eye-opening moments, right? Where you're like, oh, I've been doing that. That's not so good. So, one of the humbling moments, I guess.
Um, I have not read the book, although it was passed along to me. But one of the things and you already have a little bit, but I'm hoping that you may talk about are some of the uplifting parts of the book. I feel like I'm gonna cringe like too many times for it to be enjoyable. So all the more uplifting moments may encourage me to pick it up and read it.
I guess the way that it sounds from talking about it is that it is a depressing book, but I did not think it was depressing at all. I thought, there were certainly moments in the narrative that were, I guess cringy, where you're like, oh my gosh, I can't believe that happened. But the way that he looks at it is very like just kind of through this lens of this is where we are as a society and this is how we can move forward. We should look at this and examine it and try and do it better next time. That was how I felt reading the book. Elizabeth, what do you think?
Yeah, there's a really good, several of the stories that he highlights are where there was that cringeable moment at the beginning, but it was the story is more of how they turned that into a positive relationship.
Mm-hmm.
And there's, he makes a couple of comments at the end. He says, if Keith and I could find common ground despite the huge differences in our backgrounds and attitudes, then why should it be any harder for other doctors to form strong bonds with patients of another race? Many doctors have done so, of course, and I'll bet they've made the same discovery that I have. A big part of the solution is discarding your assumptions and connecting with each patient as a person. Race, while certainly a powerful influence by itself, does not guarantee a human connection. And so I think he ends on a fairly positive note, and I'll save it for the wrap up here at the end, but there's 3 things that he shares that are kind of like future steps.
Yeah, I think for every story, there was like, it wasn't like, oh, this is a terrible story and there's nothing we can do about it. It's all awful. I think for every story, there was, here's what we can learn from this and move forward. But I have read books that are very depressing before, and this was not one of them. Let's see. Any other comments on the stereotyping? I guess I can move on to question number 3 there. Thinking about your own practice, have you ever found yourself stereotyping a patient, a colleague? And this is I kind of talked about the putting race first in the chart, but the other things that we put in charts that I kind of mentioned earlier that then lead to inevitable stereotyping down the road. And I mentioned earlier the mental illness diagnosis that was unfounded for the one patient. But also, you know, people will very frequently put in the first line non-compliant patient or former opiate user or former alcohol user. Or you know someone who has been incarcerated. um, those things color how you see the person before you even walk into the room. And I think even you know the race identification aside, I think it's important to think all um, like every word that we put in the chart in our narrative is going to have an impact down the road in how the next person sees that patient. And I've certainly been subject to that before too, where you know someone will have, I'll pick up the chart and it will say opiate abuse, or it will say um, alcohol abuse, or it'll say non-compliant, and I will have a mental image walking into that room of who I'm going to see. And so I've done that time and time again. So I think it's important now, like moving forward, to make sure that um, that I recognize that that's happening and try not to let it influence what I think about that patient before I even meet them. Um, Another thing that I think has we've been, and we may talk about this in a future session, is obesity. That's something that has been, I think we're moving in a different direction as a society and how we view weight compared to where we were, you know, 20, 30 years ago. But the way that I approached patients 10 years ago who were overweight um, is very, very different than how I address people now who are overweight. And I can say that, you know, years ago when I'd walk into the room and see someone who was obese, that was the first and maybe even the only thing I talked to them about. And I feel really terrible about that now. But I think that's something that probably we need to, that's something that I'm guilty of as a professional, and I'm trying to move forward with, you know, is that again the most important thing that I need to talk to the patient about today? And so that I just wanted to share that. Has anybody else seen any of those things? Have you seen those things in your practice that you're like, oh, I did, you know, used to have this bias and I'm moving past it, or there's a bias that I have now that I'm trying to move past? I know that can be hard to share.
Hello, Lucretia again. I can
Yeah.
say a bias that I've seen and still see a lot of is based around the indigent population.
Oh, yeah.
That is one where we do have to be careful of the verbiage and the description that we give, because oftentimes when you go into the room and speak with the patient, they are more delightful than what you would have ever thought because of their situation. And you can't judge them based off of a situation, more of what moment they're in at that time. And just listen to them as a person with, as I guess, without judgment, because you will want that same respect or, you know, that same type of, due diligence. You wouldn't want somebody to do you like that. And I have noticed that throughout practices that I've gone in rooms and they are a delight, and hearing their story doesn't always match. And
Yeah.
it just makes you want to do more for them.
Yeah.
And that's what I kind of gathered when he spoke about the lady with the drug use, because oftentimes they are both. They have both, they're indigent as well as having an issue with some type of substance abuse.
Jeanette Berg here. I just want to comment that I think it takes time to get to know someone, and so I would say that there's always this pressure between productivity, how efficient we are, how many patients we either have to see because they're in the hospital and they are our responsibility, or kind of number of patients in clinic, and that can push against having that time to get to know people. And I think being cognizant of it and recognizing that there's value in getting to know our patients, and having that be a reason why we need time to sit down and have a conversation and can't just rely on a blurb in the medical record and go from there.
Right. Absolutely. That kind of balance, yeah.
This is Christy on 3 East again. We have very rooms and lists, and I think it's been something I've been thinking a lot about with inclusive care, just that specific population. Sometimes it takes more than 1, 2, or 3 people to help get personal cares done, but that personal care is so important. And I think that sometimes cares are not done, and then I personally experienced that with a loved one here in this hospital, and it was just heartbreaking. And I don't put any offense to it, but you're like, wow, what do you try to do? I know I worked on 1 North for a long time, and I'd always want to try to take care of those patients, just because there is a story behind the why of sometimes that morbid obesity.
Mm-hmm.
I did see, Christy, you asked us to address that in a future session, and we've been talking about that off and on quite a bit. I see that there's some interest there. I think that would be really great to include this year in one of our upcoming lectures.
Yeah.
Let's go to our last question here. So maybe even speaking of this last conversation we were having, throughout the book, Dr. Tweedy displays an enormous amount of vulnerability to showcase his own professional and personal growth. So really the whole point of why we do this book club is what lessons can we take away from his example of this and into our own lives? And how are we different as practitioners after reading this book? Personally, I found the intersectionality that he highlighted to be very interesting. Not just somebody's race that contributes to their outcomes, but their economic status, their education, their upbringing, all of these different factors and how they intersect for that one patient in that one instance, and how is that going to impact their care. And so when we think about our mission as an organization, we improve health one patient at a time, and being able to give ourselves, like Dr. Berg talked about, that time to really make those connections and really understand people one by one so that we can really care for them as a human in that instance. Any other thoughts as we wrap up here?
I think another takeaway that I took from it was, and I've mentioned this a couple times already, but the ability to be able to look at yourself objectively and share, what you see your faults as, to be vulnerable and say, oh, yeah, I screwed up there. I need to do better in the future. But to say that out loud, you know, to other people, I think, like for me, hearing him do it makes me feel more comfortable being able to share my faults and my vulnerabilities and my, like, you know, the things that I stereotype about. And I'm thinking that, you know, the more that we can do that as individuals, the more people around us are going to feel comfortable, you know, sharing and visibly trying to work on those vulnerabilities or those issues in the future. So that was my big takeaway from it.
Thank you. So I'm just going to close with the kind of 3 different problems he outlines towards the end and what we might do about them. So first is there are system-based disparities that limit Black people's access to medical care and people in general, but Black people are disproportionately uninsured, and if insured, more likely to have public than private coverage. So he speaks about the need for system level changes, which starts with government and insurance companies. And then second, he gives this advice that the doctor-patient relationship itself serves as a catalyst for differing outcomes. So attitudes and behaviors on both the part of the doctor and the patient, or your nurse and your patient, or whoever might be caring for this patient, are important. And I think an opportunity to potentially make change in somebody's life. And then he does talk about the lifestyle behaviors of people who are Black and how those are, you know, contributed to some of the most heartbreaking stories in his book. And so that really takes not only systemic change, but individual and community level change. So we're all sort of in this together to improve the health of our neighbors and our colleagues and our friends. And he does say, despite the tragic stories I've written about in this book, there are clear signs of progress. Nationwide, teen pregnancy, infant mortality, and violent crime amongst Black people are all down from where they were when I entered medical school in 1996. Between 1996 and 2010, life expectancy of Black males increased by more than 5 years, far exceeding the gains made by any other group during that period. And recent estimates put the narrowing Black-white life expectancy gap at less than 4 years, when it was twice that a half a century earlier. So he's saying that the foundation has been laid for continual improvement, and that gives me a lot of reason to want to keep working on something that can be very challenging and gives a lot of hope. So I want to thank everybody, and thank you on behalf of Dr. Peterson as well for attending our book club today. We really appreciate you and your willingness to share and be vulnerable, and your willingness to learn and to discuss these topics that are often very difficult. So just to let you know, we've already picked our next sort of theme for our next book club, and it's going to be around economic diversity in healthcare and those socioeconomic differences and how they change how we care for patients and how we're even allowed to care for patients in some cases. So that will be in June. So you can put it on your calendar now, and we'll get an invitation out when we have more information about what we will be reading, and hope to see you all there. Thank you.
Thank you, everybody.